Hello, my name is Dr. Melanie Bourgeot. I'm a third-year pathology resident at Emory University, and welcome to the second video in my Adnexal tumor series. In this video, I'm going to be discussing a variety of adnexal cysts and cystic adnexal tumors. Before we get started, I just want to remind everyone that I provided links to the whole slide images of the cases we're about to go over, and you can find those in the video description. Our first case is an excision of a bluish papule on the eyelid of a 55-year-old female. At low power, I can see we are dealing with a multicystic lesion, and that some of these cysts appear a little more complex than others, like this one right here. And if we go into higher power, we can see these papillary structures lined by uniform, relatively bland cuboidal to columnar cells with amphiphilic to eosinophilic cytoplasm. You can also see that some of these cells have these tufts or snouts where the cytoplasm looks more eosinophilic and granular. There are also areas where the cells appear to be a lot more squished or bunched up, like here, and this almost imparts a pseudostratified appearance. Furthermore, there are also areas like this one right here where you can see a clear double layer of cells, with the columnar apical cells overlying the more flattened basal cell layer. So this is an example of a cyst adenoma, which is a benign sweat gland neoplasm. Before we discuss the differential, let's review some normal histology. Both eccrine and apocrine sweat glands have a double layer of epithelium, with cuboidal to columnar apical cells and flattened basal cells. There are several differences between eccrine and apocrine sweat glands, the first of which is the appearance of the apical cells. In eccrine sweat glands, the apical cells have amphiphilic to clear cytoplasm, while apocrine sweat glands have that characteristic granular eosinophilic cytoplasm with apical snouts, which you can see here. Another difference is the method of secretion. Eccrine sweat glands secrete directly onto the skin surface, while apocrine sweat glands secrete into the hair follicle. The last difference is anatomic site. Eccrine sweat glands are present throughout the body with a higher concentration in the palms and soles. Meanwhile, apocrine sweat glands are only present in the areolar tissue, axilla, and groin. In case you're wondering why I'm taking the time to go over this, this actually can be important to know when identifying and diagnosing some adnexal tumors. For instance, if you watched my last video, you'll recall that nevus sebaceous, which arises predominantly on the scalp, has apocrine sweat glands that secrete directly onto the skin surface, which is very abnormal. For cystic sweat gland lesions, there are two main diagnoses to consider: hydrocystoma and cystadenoma. Both are benign neoplasms that commonly present as one or more bluish or translucent papules on the face of an adult, most commonly near the eyelid. The only difference is that while hydrocystoma has a simple double layer of cells, cystadenoma has areas of thicker, more complex epithelial lining. Both can have apocrine and/or eccrine differentiation, but this is not of any clinical significance. A rare entity that can present as a cystic lesion is endocrine mucin-producing sweat gland carcinoma, which is a low-grade malignancy thought to be a precursor of primary mucinous adenocarcinoma of the skin. Unfortunately, I don't have an example of this to show, but if you'd like to learn more, I've included a link to a recent paper in the description. Moving on to our second case. This is a skin-colored papule with a central pore on the nose of a 70-year-old male. Now, this is kind of a wimpy example, but I think it's good to show because, unfortunately, in reality, not every case is going to be a perfect textbook example. At low power, there is a cystic space containing keratinaceous material, which opens up to the skin surface. At first glance, it looks a bit like a hair follicle, except there are multiple projections budding off of it, including multiple sebaceous glands. At higher power, some of these buds definitely give off at least the suggestion of follicular differentiation. In addition, you can also appreciate a dense fibrous stroma surrounding the lesion, which is distinct from the adjacent dermis. This is an example of a trichofolliculoma, a well-differentiated benign follicular lesion. It is composed of a central dilated hair follicle with multiple, smaller, immature hair follicles budding off of it. This is commonly referred to as a hen and chicks arrangement, with the mother hen follicle surrounded by the baby chick follicles. The central cyst is lined by stratified squamous epithelium, similar to the overlying epidermis, and contains loose keratin as well as fragments of hair shafts. The differential for a cystic follicle includes other rare entities, all of which are non-neoplastic or benign. The most distinct is sebaceous trichofolliculoma, or folliculosebaceous cystic hamartoma, which is basically a conventional trichofolliculoma, but with only sebaceous lobules budding off of it. Dilated pore of Weiner is essentially just a dilated hair follicle, with nothing coming off of it except for some occasional thin, finger-like projections of epithelium. The last differential, which I unfortunately couldn't find an example of, is pilar sheath acanthoma, which is similar to dilated pore of Weiner, except the epithelium is thickened with bulbous projections. Before I end this video, I do want to briefly mention some other cysts that may enter the differential. The first is steatocystoma, which is lined by stratified squamous epithelium without a granular layer. The epithelium has a wavy or shark tooth surface covered by a pink cuticle, with associated sebaceous lobules secreting material into the cyst. Next is pilar cyst, which is one of those nice 1x diagnoses thanks to the dense tricholomal keratinization. When you actually look at it under the microscope, which you should always do, you'll see that it's lined by stratified squamous epithelium without a granular layer and abrupt, dense keratinization. Last but not least, we have epidermoid cyst or epidermal inclusion cyst, which I know isn't exotic or exciting, but is probably the most common skin cyst you'll diagnose by far. I'm still in training, so I'm hesitant to give out advice, but I think my one piece of advice for residents regarding these lesions is that if you're thinking of diagnosing something cool or exotic, like a dilated pore of Weiner or a pilar sheath acanthoma to impress your attending, it's probably to your benefit to include epidermal inclusion cyst on your differential, unless you see something that really raises your suspicion for another lesion. And that's all I have for now. Please like and subscribe, and you can follow me on Twitter and Kiko for more educational pathology content. I've also recently organized and put all of my posts in one place, so if you would like to check that out, here is the link, and you can also scan a QR code right there that will take you directly to that link. Thanks for watching!